friends and colleagues. Today's going to be a little bit less formal than a typical Grand Rounds, and I appreciate everyone who carved out some time to learn about this important public health issue. I know we didn't give much notice at all, but the story behind it is, so first of all, hi, everybody. I'm Gloria Reeves. I serve as the Research Vice Chair in Department of Psychiatry. But I'm also a citizen of Maryland and a mom, and like everybody, I think in our community, concerned about measles outbreaks, a topic that I learned about from a more theoretical perspective when I was a medical student, but never treated a patient with measles during my medical training. But on Sunday, we heard about a case identified. Oh, sorry, it looks like there's an issue with the audio echoing. Dave, can we just mute people for the presentation, and then people can just put questions in the chat and we can unmute when you do that? Is that fine? Okay. All right. Can somebody give me a thumbs up? Is the audio okay? Can you hear me all right? Okay, beautiful. So on Sunday, there was a news article came out about a confirmed case in Howard County. So unfortunately, we knew there was a case of measles here in Maryland. So since everybody on this call are folks who have a large, are what I call our circle of influencers in mental health in our community, we thought it'd be really important to provide information so that we can disseminate as the situation's evolving, and also to get to meet one of our wonderful experts and colleagues in our School of Medicine family. I will say, I think that it's really a wonderful part of being on the faculty here at University of Maryland, as I feel like this is sort of the buffet of experts where I can reach out whenever there's a question or concern, and people are so generous with their time. So Dr. Schrank was notified of this request and responded back within, immediately that he was available this week to give a presentation. So I'm delighted to have him join our Brain Trust today. I didn't ask him to write up a bio for me because I thought it was nice enough for him to give a talk. So Greg, maybe you can introduce your official title. So I know you're Assistant Professor of Medicine, and you're in both the School of Epidemiology and Public Health, as well as on the faculty at Shock Trauma. Is that correct?
Yeah, thanks, Dr. Reeves. Again, I appreciate the invitation and always happy to come speak with you all. So I'm an assistant professor of medicine in the Department of Medicine. And clinically, I practice in shock trauma as an infectious disease consultant. And then I'm also a faculty in the Department of Epidemiology. And so I'm one of the physicians on the infection prevention team for the hospital, which is part of the role of me being here with you today is educating and trying to alleviate some concerns, answer a lot of questions around measles, and get, as you said, get out the good word. So
yeah. Well, we owe you one. You need to talk on any mental health topic, you call me and we'll make sure we bring an expert. So we're very grateful. So
no, you're welcome. I have a soft spot for psychiatry as well because my family is full of them, full of psychiatrists, including my spouse. So I'm always happy to come to the
yeah. You're a member of the fold, then you're part
exactly
of the
exactly.
So I think our plan is to have a brief overview, kind of PowerPoints, but also have a lot of time for Q&A. So if you know you have a question already that wasn't on the list of questions that we had already sent, Dr. Schrank, if you want to put in the chat, and I'll try to moderate and keep an eye on that. But please take it away, Dr. Schrank.
Great, thanks. Let me share. Okay, you guys should be seeing slides now, right? Yep. Okay, great. All right. So we already went through introductions, so we're all set there. We'll be talking about, of course, measles today. I have about 15-20 minutes worth of content and then plenty of time for questions. Similar to yourself, Dr. Reeves, I have a disclosure in that I've never seen a case of measles, at least not in person, myself. But we were taught extensively about measles in medical school, and then again, as part of infectious disease training, but mostly in the context of travel-related measles cases, potential management of post-exposure, and then of course vaccination. The other disclosure I should add is that I'm an adult ID physician. My initial residency training was in internal medicine. And so we'll focus a lot on measles and its involvement in children, but my training is mostly in adult medicine. Okay, so just a quick overview. We'll talk about epidemiology, measles in the past, the current outbreaks in 2025, a little bit about the clinical presentation of measles and some of the more severe, less frequent complications, vaccine guidance, which, as I know, an area of particular interest for this group, some considerations of infection prevention, and then that will lead us into questions. So measles virus is far and away the most contagious cause of any human infection. I think we all over the last few years became pretty familiar with the contagiousness of COVID and influenza. We became more acutely aware of how contagious some of those respiratory viruses can be. Measles exceeds that by quite a bit, actually, all of those viruses. It's transmitted primarily through droplets in the air, like other respiratory viruses, but it is fairly unique in its ability to linger in the air in these tiny aerosols, these tiny particles that are suspended in the air. And there have even been investigations and air sampling studies that have identified contagious measles virus present in the air for hours after a patient, an infected individual has left an enclosed space, which is one of the reasons, as we'll get into, why adequate air circulation and ventilation is really key to control of the virus as well. It has what's called a secondary attack rate of 90%. This means that if an individual is exposed to somebody with measles, there's a 90% likelihood, even after a fairly brief interaction, that that person will have been exposed to measles and go on to become infected if they're susceptible. If you look at studies, especially pre-vaccine or early vaccine era investigations of outbreaks, if you have an entirely susceptible population, meaning that almost everyone is non-immune to measles, one case will infect about 12 to 14 additional people. That's compared to COVID, which is somewhere around 2 to 4, or diphtheria, which is also a very, very contagious infection that's somewhere around 6 to 8. So this is well beyond anything else that we typically encounter. One of the reasons why that's the case, this is, I promise, one of the only microbiology pathogenesis slides I have, is that it's very unique in how it enters into our body and spreads throughout the body. Most respiratory infections, when we encounter them, we inhale them into our respiratory tract, and they adhere to the lining of the respiratory tract, the epithelium. That's what triggers some of those early symptoms that we have, like sore throat, nasal congestion, runny nose, things like that. And that pretty much immediately, or at least over the first couple of days of illness, leads to then expectoration and shedding of virus. The contagious period, for example, of influenza is usually within a day or so of the onset of symptoms, because it's immediately infecting the epithelium. It's very different for measles. Measles, when it's inhaled, actually adheres to the macrophages and dendritic cells of the in the distal alveolus. So it travels all the way through the airways, and it's got this unique receptor on its a viral envelope that helps it to affix itself to a protein called SLAM. It's basically a receptor on immune cells of our airways. And so it initially, rather than invading into the epithelium, it actually starts to spread through the immune system via our lymphatics. And so it ends up infecting many of our lymphocytes, macrophages, and dendritic cells throughout the entire body before making its way back into the respiratory tract and being exhaled. And so the viral load at the time of the onset of systemic illness is extraordinarily high. So there's a very, very high concentration of measles virus in exhaled breath in an individual who's symptomatic and infected with measles. And then when you add into that its ability to linger in the air, those two things together make it extraordinarily contagious. Okay, so measles was ubiquitous leading up into the 1950s. It was thought to be a rite of passage, so to speak, of childhood, where pretty much every individual was exposed to measles before the age of 10. Um, Most people who experienced it, particularly in well-resourced settings, it was like a bad cold. I'll get into that a little bit in the clinical presentation. But this is also one of the reasons why it was targeted for potential elimination and even eradication through vaccine efforts. Measles only infects humans. It's not, it does not have a reservoir in any animal on the planet. And it was just so ubiquitous and highly contagious that even with very rare severe outcomes, the sheer high volume of cases that were people who were newly infected every year across the United States ended up contributing to fairly high amounts of morbidity just because there were millions and millions of new cases infected every single year. The vaccine was introduced in 1963, just a few years after polio vaccine efforts got underway. There was initially two different vaccines that were available, and there was still research underway as to whether or not one or two doses was adequate. An outbreak that you can see there in 1989 and 1990, actually not that long ago, led to modification of the vaccine guidance to its current state, which includes two doses in childhood. It was declared eliminated from the United States in 2000. You can see there are really flat line of deaths, at least, with some periodic increases in cases in the early 2000s. Really what that means is that it's just not naturally circulating through the population whatsoever. However, as you may have read in the news, that's that determination, that classification is actually being reconsidered right now, just given the sheer number of outbreaks. Okay, so then this is what's going on now. The CDC is updating its website, I think only once a week, just for the time being. So this data is a little bit old. I know that there have been some reports suggesting that there are more cases than what I have here, but this is just from, I think, as of March 7th. 12 states this year have reported cases beginning with January 1, 2025 to present. Includes some around here beyond just the case in Howard County, including cases in New York City, New Jersey, and Pennsylvania. But of course, the largest outbreaks are concentrated in the western parts of Texas, in some counties just adjacent to the New Mexico border, and then over into New Mexico as well. So you can see there are a total of 222 cases. The majority of them are in children and teenagers. However, there are still a number of infected individuals that are 20 and older. The overwhelming majority, I should say, of infected people are of unknown or unvaccinated status. And with just a couple of individuals with a history of receiving the MMR vaccine that have gone on to develop infection. And you can see there's thus far a 17% hospitalization rate, which tracks actually very, very closely with historical data, which was estimated around the 20% hospitalization rate. So as I mentioned earlier, for most people that experience measles in the pre-vaccine era, or even today, it's like a bad flu-like illness. The incubation period is actually quite long. That's because of that initial first step in pathogenesis of really invading the immune system and circulating through our immune system before entering back into the respiratory tract and contributing to respiratory symptoms. Fever, cough, and runny nose are fairly common. They are common, of course, in other respiratory infections. One thing that is extremely common and not unique to measles, but very prominent in measles is conjunctivitis. So inflammation that's very, very apparent of the eyes with drainage from the conjunctiva. Something that's pathognomonic but is not always present are these, you can see there in the top right picture, what are known as Koplik spots. These punctate white lesions on the inside of the oral mucosa, generally about 2 to 3 days after the onset of symptoms. So maybe not present at the first onset of fever, but certainly would develop a few days later. And then a very characteristic rash that begins on the head and face and spreads downward. It's macular, meaning it's a flat red rash, very blotchy, not particularly itchy, just very, very striking. And you can see they're extremely dense in throughout the body. That typically occurs about 3 to 5 days after the onset of respiratory symptoms or fever. Okay, so a little bit about complications. So most people, I should say, their symptomatology will be limited to what I just had in the previous slide, and then over a week or so they will recover, including resolution of the rash. There are complications, though, some of which are more common than others. Otitis media affects middle ear infection affects about 1 in 10 children. Diarrhea is also prominent and is a source of morbidity, particularly in low and middle income countries where there may be more challenging access to emergency care. And it can sometimes be severe, particularly in very young children. Pneumonia affects about 1 in 20. This is the primary source of hospitalization, or cause, I should say, of hospitalization and cause of death in children, as well as pregnant and immunocompromised individuals. About 1 in 20 who are infected with measles will go on to develop pneumonia. And then encephalitis, thankfully, is very rare, but can be very highly morbid and contribute to long-lasting neurologic sequelae, including deafness. There's a very, very rare but unique complication of measles, something known as SSPE, or subacute sclerosing panencephalitis, which I told you I'd never seen measles, so of course I've never seen this in my career either. But as a essentially a neurodegenerative disorder that presents 7 to 10 years after the onset of the acute infection, and it's due to really viral persistence in the central nervous system. And then there is this also unique feature of measles that I think is underappreciated, but is I think, at least from my perspective, one of the most concerning features of the virus, in that because it initially invades and is very, very prominent in its replication within memory B and T cells, when our own immune system is clearing the virus, it actually ends up eliminating infected memory B and T cells from our body. And so we have this transient depletion of immune memory. In children, that includes all the viruses and bacteria that they've been exposed to during early childhood. And even though our body is very quick to recover our B and T cell counts, they, in essence, don't have the same immunologic memory that they did prior to the measles infection. And so there's an increased risk of secondary infections for years afterwards. Okay, moving on to vaccination. So as you all likely know, measles vaccination is part of the MMR combination vaccine, mumps, measles, and rubella. It's a 2-dose regimen given around the first year, around when the child turns 1 year old, and then again at 4 to 6 years of age. It's really intended to be given before entry into primary school. The doses need to be at least 28 days apart, regardless of when they're administered. And 2 doses, when given at that schedule, has a 97% efficacy of preventing infection, and 1 dose has about a 93% efficacy of preventing infection. So you notice there that even though it's routinely given to children now, not the vaccine schedule as it's currently constructed was altered in the 80s. And so not every person has received 2 doses of MMR, whether that because of the vaccine schedule differences, or maybe they missed a dose, or in their country of origin or location of origin, they hadn't received a second dose. So who needs to have 2 doses? Who is it really recommended to have 2? You can see the list there. All healthcare workers, it's strongly recommended, and in fact, required to have demonstration of immunity and have received 2 doses of vaccine. International travelers, it's a recommendation prior to travel, particularly into areas where measles is much more endemic. Immunocompromised or family members, people who live in the same home as immunocompromised individuals, and then people who are living in an area of ongoing outbreak. So there is this definition of presumptive immunity, in part because vaccination occurs in early childhood and not everyone has this access to their medical records. So those are the criteria used to define immunity by the CDC. Most often it's documentation of vaccination, but serologic testing with antibody titers can be used as well if you were actually infected with measles and that was confirmed by the laboratory. And then because of the ubiquity of the virus in the 1950s and earlier, birth before 1957 is considered presumptive immunity, although this is not used as part of the criteria for healthcare workers. Because I know that this comes up quite frequently, if there's uncertainty or an inability to confirm records, antibody titers can be used, though that's not always feasible. And the CDC's deference, along with public health agencies across the country, their deference is towards readministration of the vaccine if that's just easier. But certainly antibody titers can be used.
We have a lot of needle phobia in our patient population, so much appreciated for that flexibility.
Right. Yeah. Unfortunately, whether it's a blood draw or a vaccine, there's a needle involved, but at least if you just go straight to the vaccine, you don't have to deal with the blood draw first. So yeah, and I can get into this, but there have been studies looking at the safety of readministration, or I should say, vaccination in the context of uncertainty, or even there have been some clinical trials looking at the third dose that have demonstrated high safety with additional doses of the vaccine. So that's a good segue. There are no current recommendations for a third dose for any adults. There are 2 circumstances where a child may receive 3 doses during their lifetime, and that's really in the context of either really in the context of international travel or as part of an ongoing outbreak. So if you have a young child that's planned for international travel, you can vaccinate earlier between months 6 and 11. And then once a child turns 1, the standard vaccine schedule is done. You can also use an accelerated vaccine schedule for unvaccinated children over the age of 12 months, or even children over the age of, that are about to enter into primary school that didn't receive their initial vaccine. You can give 2 doses just a month apart. Adults who are at risk because of whether they're immunocompromised or maybe they live with someone who's immunocompromised or in an area of outbreak, if they have only received 1 dose, they should receive a second. Local guidelines, like they're doing in Texas and New Mexico, may adapt some of these protocols, including earlier vaccination of young children 6 months and older. There is one important contraindication, is that the MMR vaccine contains a live attenuated measles virus. It's actually more effective than the inactivated virus. Both types of vaccine were available in the 1960s, but because of much lower efficacy with the inactivated virus vaccine, it was transitioned to just using the live attenuated virus. But it cannot be given to immunocompromised individuals or during pregnancy. Okay, a few just tips for how you can get your patients if they need a vaccine. Of course, primary care offices are certainly capable of doing this. The FPI Family Medicine Clinic here at the School of Medicine has MMR vaccine, the Midtown Pediatrics Clinic as well. Commercial pharmacies generally all carry the MMR vaccine, though there would likely be out-of-pocket costs if for an uninsured individual, in which case local health departments, MDH has a list that they've developed of all local health departments that are capable and stocked with the MMR vaccine that could offer it to uninsured persons. Okay, so just like two slides on or so on infection prevention, and then we can get through some of those questions. So uh, what we use in the hospital is airborne droplet and contact precautions. So this is primarily a disease that's transmitted through aerosols. So that's the airborne isolation. That includes a private room with negative pressure or with a HEPA filter in place, and then 95 respirator, eye protection, gowns, and gloves. The contagious period is defined as 4 days prior to 4 days after the onset of rash. So for about 8 days. At which point in time, even though an individual may remain symptomatic, they're no longer contagious. In an outpatient, if you were to be seeing somebody who you developed clinical concern for measles infection, that individual, at least for outpatient infection prevention management, because negative pressure is typically not available, rooming an individual in a private space, isolating them, closing the exam room door, masking the patient, and then contacting infection prevention for next steps is the way to go. So this is signage that was developed by University of Maryland Medical System that is in the process of being distributed to all points of entry and to other ambulatory locations. These are some of the questions that we're focused on right now. It's the high fever, cough, particularly the conjunctivitis, as I mentioned, and then rash. So any febrile rash, any febrile illness with a rash, really at this point, given the current context, should raise the suspicion quite a bit for potential measles. Also travel to an area with ongoing measles outbreak. There have been protocols. This is small, and I wasn't necessarily intending it for you to digest this information, but there have been protocols developed for screening at triage sites within the emergency department and a registration in outpatient settings to ask individuals, as you can see there in the top right of both algorithms, to ask the patient about cough, runny nose, red eyes, providing the patient with a mask, and then performing additional history to confirm whether or not they should be considered a measles suspect and then triaged accordingly. Regardless, infection prevention through both Tiger Connect and then on campus at the hospital here through at our phone number 85757 is the best resource if you have any questions about a potential measles case in when you're evaluating a patient and asking questions around how best to isolate them and what next steps might be. And we can also help with assessing the potential risk and of whether or not they are in fact a measles rule out. Those are all the slides I had. So at this point, maybe we could move through some of those questions I know we have.
Yeah, so we've clocked in at 90 people so far at this
Great.
talk, which is you're quite a draw for such a last minute invitation. So thank you for such an informative talk. It's all sounding familiar from medical school, but now it's like back into my current memory banks. So we have a bunch of questions. I'm going to start with the early ones and go to the more recent. So there
Okay.
was a general question about is there any concern because we have so many unvaccinated children that at some point the virus will mutate and these immunizations are not going to be as effective? Is there any signal to raise that concern, or is that more a theoretical risk at this point?
Yeah, that's a great question. That has not been observed whatsoever. The vaccine, in part because it's a live attenuated virus, it confers really, really effective high-level immunity that's considered to be lifelong. There might be some waning, but frankly, because the vaccine was also first available in the early 1960s, children at that time are just reaching the older decades of life, and there haven't been large population level studies to understand how effective they remain. So there may be some waning of immunity, but generally titers have held up very well over the decades of life after vaccination. And even at the time when the vaccine was initially developed and rolled out, there were still around then millions and millions of new cases of measles every year. So unlike some of the other respiratory viruses we deal with, like COVID, like SARS-CoV-2, there was not that rapid evolution of mutation that we've seen.
Okay, well, that sounds encouraging. and hopeful. If for folks who are considering international travel with a child who hasn't been vaccinated yet, is the recommendation for early vaccination just to places where there's measles are endemic, or would you say like across the board, it's just wise to get it done?
Yeah, it does. Certainly, the level of endemicity would increase the risk, though there are many places, pretty much on every continent, that have some level of circulating measles, and many of the cases that have been imported into major urban centers on the East Coast are related to travel in Central Europe, and in areas that we might think of as being well resourced and have high access to vaccine. And so generally, international travel should prompt at least a discussion with your pediatrician, your child's pediatrician, as to whether or not they should receive the vaccine. But I think if you're planning travel with a child between 6 months and 11 months, I absolutely would check in with your pediatrician. And we have through CDC and other resources assessments of the level of risk based on the location of travel. But I mean, personally, I think I would err on the side of caution and at least having that discussion first before bringing a child abroad.
Yeah, and somewhat related, my sample size of 4 parents who have a child who's under the age of the standard vaccination, so like 6, 7 months. Um, we've heard from them that pediatricians sort of vary on their willingness to give the vaccine early. Are there AAP guidelines on that about when it should be given early? Do you encourage people to sort of advocate for that?
Yeah, I think one of the benefits of having the vaccine schedule as it's currently designed is that having some distance, temporal distance between the two doses really does improve the effectiveness of the vaccine to provide the long-lasting immunity. And that was really part of if you go back to the late 1980s and early 90s, the decision to vaccinate once again prior to entering into school to formally include 2 doses, it was separating the 2 doses far enough apart so that the vaccine was safe to give once the child reached 12 months. It's certainly safe to give once they reach 12 months. And then again, boosting immunity prior to entering into school, which is a primary location for transmission. So having the vaccine separated by a few years actually really helps with the immune response. And so what I would say is that this will be I think a determination made between really at the by public health authorities within jurisdictions that are experiencing an outbreak. The case in Howard County in our area, and then in some areas in the Northeast, generally have not been linked, or actually I should not say generally, they have not been linked to the outbreak in Texas. They have been imported cases. And so I think if we were seeing a level of transmission within Maryland that was concerning for intrastate, spread of the virus, I think that then there would need to be discussions at the county and state level about advising pediatricians on earlier vaccination. For now, I think with a single imported case, we're not there yet, and that for most children, it is much preferred to stick to the standard schedule. A single dose is quite protective. It's not that we aren't seeing any level of protection. It's just in the 80s, when there was a resurgence of cases, we saw that there was enough there were enough susceptible children still after 1 dose that the decision was made to add a booster.
Okay. Okay. So there's some advantage to wait, but
Yeah.
but we have to kind of keep up to date with what the guidelines are, because if the number of cases spread or there's intrastate travel, then we would be more concerned, it sounds like.
Yeah,
Okay.
that's right.
There was another question about measles in other countries. So in international countries where measles vaccine is given, but the child still ends up getting measles at an older age, is that a phenomenon related to they don't get the second dose, or is there something about vaccines used in other places that maybe are not as enduring in its protective benefits, or any thoughts about that?
Yeah, well, that's a great question. So, in other countries where measles is more endemic, Right. Even in the United States, when you look at the cases from Texas, there are still a couple of people who have become infected that were vaccinated. It's not 100% effective. It's somewhere like 93 to 97% effective. So if you have enough cases, you will see individuals getting infected that have been vaccinated. Thankfully, that infection amongst vaccinated people is much more mild, and the risk of complication is substantially lower. That doesn't necessarily apply to immunocompromised individuals because they might not actually have the antibody response capable of fighting off the virus. But for an individual that's not severely immunocompromised, the vaccine, even in the would protect them even if they do get infected. And
Okay.
so what might
It
be
protects against
referred
the
to.
real serious effects.
That's right. And even the level of contagiousness is lower, the rash resolves more quickly, the symptoms are shorter in duration, and they're much less likely to spread the virus to others. So that is one thing that's seen in other countries is vaccinated people, just because there's more measles circulating, may actually end up getting measles, but it should be much more mild and less contagious.
Okay, great. Then we have another question about just the ingredients in the vaccine and saying that somebody refused a vaccine because of porcine ingredient or something like that, and they have a dietary concern related to that. Do you have a comment about that? I'm sorry, I don't know what the exact ingredient is, but
Um, I don't either, truthfully, off the top of my head. I mean, I do think that there have been, for both, I would assume that this is like maybe not an allergy related question, maybe more of a religious concern, but
yeah,
I'm
or some kind
not
of
sure.
dietary
Okay.
preference or
Yeah, I mean, there, one of the contraindications is certainly, um, and any allergy to any ingredient. If it is more of a religious concern, I think that that's a conversation that it requires a little bit of a different discussion. It's a conversation around the well-being of your family and having the opportunity to protect your family despite some concerns about the ingredients that may be present. Um, I don't know that I have like the magic answer for how to approach those, but hopefully your relationship with that patient is one of, that's filled with trust, and you can maybe even engage a religious advisor or an individual that they could seek counsel from to discuss the vaccine with, particularly knowing that there's lots of outbreak around the country right now. And I think that in general, when we talk about vaccine reluctance or hesitancy or whatever you want to call it, there is less trust, we know, in federal agencies. There's less trust in public health and organizations like that. But generally, people, if they have a relationship with their provider, their clinician, they're more likely to listen to that person maybe than to somebody on TV or to a website. And so I think leaning into that and other trusted individuals around them is helpful.
yeah, hopefully we've learned some lessons from the pandemic experience for sure. There was another question about, and this may be related to what you said about not everybody who is vaccinated will be fully protected against getting measles in the future. So somebody used an example of their daughter went for got the titers for admission to college, and they had to get another shot because they didn't
Yeah.
even show the reaction to it. Is that sort of in that same? You could
Yep.
maybe not react in the titers, but you still have some protection, or is if you're not immunocompromised, or
Yeah, that's right. So the first dose, almost everyone will receive or have a good response. A second dose, the overwhelming majority of people, almost every single person will have a good response, but there still will be the occasional person. When you're talking about millions and millions of individuals getting vaccinated, there still will be the chance that somebody did not, and that's one of the reasons why before matriculating to college, before starting employment at a healthcare facility, we confirm vaccination, confirm titers to boost immunity if necessary.
okay. Okay. And thank you to our colleagues who clarified it's a pork gelatin ingredient. So thank you.
Thank you.
Other questions were about can you be a spreader even if you don't get it? So maybe you're vaccinated. Are you like a carrier of some type? Could that be possible?
Thankfully not, though we do know that, at least based on our current understanding. But as I mentioned, there is a phenomenon of individuals still becoming infected. It's not quite vaccine failure, right? It's just that because we know that the infection will still be much more mild and they'll still be like less likely to spread it. But those people still could be contagious, though the likelihood of developing a complication is very, very low in comparison.
Okay, thank you. Just a few more questions uh, about international travel. So, any concerns if the adults have been vaccinated in the 80s? Does that mean, oh, just the one vaccine maybe? Is that what you said, 89 or something when it changed? Like if you just had the one and you're traveling, should you get a second one?
Yes, if you are traveling and you've only received one dose, our recommendation would be to receive a second dose before travel.
Okay, thank you. And unrelated, somebody was chatting about bagpipe performance today. I don't know how I did not get invited to that. I'm gonna blame my colleagues over there for not sending me a note about that. I would love to see it. There's a note in there also about if someone received a vaccine in the early 60s, would immunity still be present? Is it really that persistent, or should you just err on the side of caution and get a boost?
Yeah, that's a great question. The decade in the 1960s into the 70s is the period of time where the alternative inactivated vaccine was being administered, and depending on where they received it and exactly what year, it's possible that that person who's asking the question may have been vaccinated with the inactivated vaccine. This would be one of those great examples of we're not totally sure. If you are employed here, it's quite likely that you had vaccine titers drawn, though it may be a long time since you had those tests done, depending on how long you've been working here. So I think that's a good conversation to have with your primary care provider. They certainly could draw titers again, or just proceed with vaccination. That decade after the vaccine became available, where both were being distributed, is the one gray area around immunity.
Okay. And here where we train a lot of health professionals, so would people who did not receive the second shot but trained after the recommendations changed, would they have gotten it? Is that like a requirement for healthcare workers
Yes,
in
it
that
should
year?
be. Yep, exactly.
Okay.
Knowing that we have different organizations involved, right? And whether you're strictly at the School of Medicine or through FPI and hospital, et cetera. But generally for healthcare workers is defined by state regulation, and the CDC should receive 2 doses and should
Okay.
have confirmation of immunity.
Okay. And one of our colleagues helpfully expanded the thought process that might be behind a parent refusing because of that gelatin ingredient, saying that that some of the rare severe allergic reactions may be attributed to that component of the vaccine. Sorry, I'm not as familiar with that, so I don't know. There's a link there. I don't know if you've heard anything about that or any comments about parents who are worried about a severe
I
allergic.
see. Yeah, and so that's like any other medication, there are very rare potential allergic reactions. Though thankfully with MMR, I mean, as you can imagine, because of discussions around MMR and other potential complications that in children, it's been extraordinarily well studied. And to date, the risks of the vaccine continue to remain far below the risks of the infection. And so the way I think about it with a vaccine is that it's a treatment that you're giving to a healthy population that doesn't have a disease, right? It's actually one of the few examples in medicine where, in particular with measles in the United States, if you go back to like 2001, when the disease had just been eliminated, for every child that was being vaccinated, there was an understanding that actually they probably would never see measles throughout their entire lifetime, right? I mean, fast forward to now, here we are. But at the time it was thinking, well, we just won't see it. But the idea
True,
was
true
prevent
prevention.
true prevention, right?
That's
Exactly.
fascinating. Yeah.
And so you need to establish a safety threshold that's extraordinary to do that. I think to be
Yeah.
confident in a public health intervention like that. There's certainly a trade-off discussion that we always talk about with vaccines, but for MMR, it is incredibly safe, and I think that we've seen so far with a 17% hospitalization rate, and unfortunately one, if not maybe two deaths attributable to measles in the outbreak in Texas, that it continues to be the best way to prevent infection and severe outcomes. And so um, concerns are very valid. Everybody should ask about any treatment that they're receiving or giving to their child. I would say confidently in this case, as an ID doc, and then as a parent of two kids that have been vaccinated, that it would be my first choice for everyone.
Okay. Just a few more questions. If somebody's traveling and they want to do their max to prevent measles, is wearing a regular surgical mask, does that do anything, or do you really have to have an N95? And do you recommend that?
Yeah, it is spread. It's extraordinarily contagious, and so it would be one of the rare instances with a respiratory infection where I would say that a surgical mask it may provide some level of protection, but not with a level of certainty that I would feel really confident in. We really do feel that an N95 or a respirator is really important for measles prevention. Is that, the individual who's infected, if they were wearing a mask, they would be less likely to be distributing virus into the
Oh,
to the surrounding area. But for a person wearing it for protection, those the kind of looser surgical masks are not necessarily protective enough for this virus.
so maybe they infect 9 instead of 12.
Yeah,
Yeah.
there are some I that's an interesting question though, and there probably have been some disease modeling that's been done looking at things like that, but
Yeah.
not in a true outbreak scenario. It would be some kind of environmental or sort of industrial hygiene simulated studies, but um, the respirator is certainly, as we think about it for care of patients
Yeah.
and to prevent exposure among healthcare workers, absolutely necessary.
Yeah. Yeah. I work in child psychiatry. So on the unit, we had the pandemic kids with the mask below the nose. You have to wear it properly and wear the right mask. It's
Yeah.
challenging. Two last questions. So one is just to clarify about the recommendations for international travel. Do you need to have both the two vaccines 28 days apart to feel comfortable traveling, or is one shot generally enough? Like for somebody who has a more urgent travel situation.
Yeah, I think getting a single dose in is certainly right. Some travel plans aren't flexible, of course. So a single dose before going abroad is much better than none. It's still going to be providing great immunity. There is a lag time. I think, note that it's not instantaneous. It's generally a week or two after the vaccine that your body is starting to really have high levels of circulating antibody. So that's just one thing to keep in mind. But one dose is better than none. Two doses is better than
Yeah.
one.
Yeah. Okay. And last question is, you're here a manager at University of Maryland. What if somebody's in a clinical role, what can you, without having to worry about it, know that they've already been screened for? Or what's like sort of the standard in our clinical system? Like if you have any kind of clinical job here, what's the bare minimum for checking on vaccines and things like that? Can you assume they've already been screened appropriately?
Oh, I see.
Yeah.
Um, so you're the context is like if you're a manager and there are people in your office or your group that you want to make sure that everybody is up to
Yeah. So
date.
not just the docs, but like the
Yeah.
therapists,
Yeah.
clinicians, nurses, everybody else.
Yeah, employee health is the resource that through their database tracks with their onboarding process immunity and immunization records. And so employee health has a database of all individuals that are employed either through the school and work at the hospital or through the hospital itself. That would be the point of contact to go to. I can imagine that they're probably fielding quite a bit of questions right now. around this. So maybe a little bit of grace and patience, but I think that they would be the ones to be able to help you with that.
Yeah, it looks like there's some chatter in the chat about like when I got hired, I was never screened or I was
Yeah,
screened or things like that. So you would just encourage people, if you're not sure, to go to employee health.
absolutely. Yep.
Okay. All right. And it sounds like the bagpiper has arrived. So I feel like that's probably a symbol we should stop. Thank you so much for being so generous with your time. I know that was about 40 questions. So we really appreciate your expertise and we reserve the right to invite you back if the picture changes dramatically in the future. And
Absolutely.
we're very grateful, and you always have a home in psychiatry. Sounds like you're comfortable being around a bunch of psychiatrists. So it's we have
Oh yeah, no,
yeah.
absolutely. Yeah, it's at home and at work. So yeah, thank you all. I appreciate your thoughtful questions and your great insights. So thanks.
Yeah, and thank you everybody who took the time to come. We have a wonderful, diverse, interdisciplinary team here who all value patient safety and safety in our community. So I appreciate everyone adding this hour to your busy work schedule. So thank you.